All right, let's move on to Alexandra. She has something interesting to show us.
All right, let me pull up my presentation. Give me 1 second.
Just
All
to
right.
add up, I believe the audience will be writing on Q&A, so I request you all to just keep that open and keep responding if you see any questions. Thank you. Yeah, go
All
ahead.
right, can everybody hear me okay?
Perfect.
All right, so starts as a medical case, and we'll know that it's going to go into surgery since it's a surgical panel. So this is an 82-year-old gentleman. I'm following his other eye for retinal vein occlusion, and this is his good eye. And he's 20/25. You can see he has a little bit of ERM and lamellar hole, but otherwise he's doing really well. And this is the image from his visit. And once again, we're getting it because we're following the other eye, but you can see that he has some retinal hemorrhages along the superior arcade. He has some peripheral drusen and a nevus, and along the inferior arcade in the macula, he has some retinal hemorrhage. So here's the fluorescein angiography, wide field fluorescein angiography of this patient, and you can see that he has multiple retinal macroaneurysms. So maybe I can pause here for 1 second and just ask the panel, 2025 asymptomatic, would anybody do anything with these RAMs other than sending him to his primary care doctor and tell him to get his blood pressure under control?
Yeah. Nothing else.
Yeah,
Nothing else. Okay. So we're in
Yeah,
agreement.
but I would not send him to his PCP, but I would say you come back, you can burst anytime.
So we know that there's more to this story, right? So I decided to watch him just like everybody else. And he comes back now a couple months after the FA. He's 2150. And you can see, I don't have the image color photo, but on OCT, he has this new subretinal, intraretinal fluid. And you can see on ANFAS that there's hemorrhage. So it looks like he either developed a retinal vein occlusion or his RAM converted to a hemorrhagic RAM. So what would people do at this point, 2150?
Nobody.
Inject?
Inject? Okay. So I agree, and we injected bevacizumab, and I told him, come see me in a month. He comes back in about a month and a half, and he's count fingers now. So I'm not feeling so good, and I can't see in the back because he has dense vitreous hemorrhage. And on the ultrasound, he is found to have a retinal detachment from 730 to 3, so inferior. And in the macula, he has a subretinal hemorrhage that is measured on the ultrasound to be about 2.9 millimeters. So would anybody like to comment what they think happened and what would they do at this point?
Was the
Raja?
patient on ecosprin, globulate, or VARF?
I'm sorry, I couldn't hear.
Was the patient on ecosprin, globulate, or one of the anticoagulants?
No, he is not anticoagulated. Great question.
Yeah, I would like to take him up for surgery, but Alexandra, the previous visit when you showed the OCT, I believe initially the angiogram showed more than one RAM, correct? So
Correct.
were you also observing the other RAMs? Were you thinking of lasering the other ramps, before they also kind of burst and cause bleeding? I don't know which one would have burst, but at this point of time, definitely surgery. And looking at the amount of subretinal hemorrhage, we are looking at probably even TPA at this point of time.
Yeah, I think it's a great point. I thought that it was the one that was most proximal to the nerve, just given the location of the hemorrhage that was misbehaving. And I was pretty confident giving him anti-VEGF, and I thought that it would tie things over. And it's interesting, and I don't know if of any literature where you have multiple RAMs, and if one starts becoming hemorrhagic, what is the likelihood that the other ones are gonna progress along the same lines? But I agree here. I think, when I look at this picture, obviously I'm concerned that he's he has more hemorrhage from RAM. But at the same time, we just gave him an injection, and with retinal detachment, I'm worried maybe there's a rhegmatogenous component as well, although that's less likely on my differential. So we decided to go in, and here's the surgery, and you can see there's dense vitreous hemorrhage. We are clearing it out. And as we clear it out, we can see that there is significant submacular hemorrhage. And peripherally, he has this large, what appears to be serous retinal detachment. We didn't find any breaks, with pretty extensive subretinal hemorrhage.
Wow.
So at this point, and maybe I can just pause for 1 second, somebody mentioned TPA. Would you still consider doing TPA, and where would you put it in? What's your kind of approach when you're thinking of using subretinal TPA, or was it intravitreal TPA?
So in this case, as you can see, most of the hemorrhage is localized to the posterior pole. Some of the cases have extensive subretinal hemorrhage, including under the retinal detachment, where you may have to kind of do an evacuation, waiting for the TPA to act for about 20 to 30 minutes during the surgery, and then do a complete evacuation. But over here, since it's just localized, at least the hemorrhage localized to the posterior pole, you may want to just inject subretinally and just put in gas and see how it displaces post-operatively. I would not do the earlier version which I was mentioning of having to wait for half an hour for the blood to liquefy completely. Over here, just a simple subretinal injection, maybe around the inferior temporal area, a couple of spots, a couple of points you may want to inject, and then just put gas inside this eye. I'm making sure that you did not create any break, or you did not see any break in this patient.
I just wanted to add one more thing here. Just wanted to take opinion from Dr. Pramod Bhinde. Would you be considering an subretinal Avastin or subretinal air in this scenario? Because
Not
many
really,
people I know,
not really, because Avastin probably we talk about when we talk about macroaneurysm, anti-VEGF. I don't think there's still conclusive role we agree upon, because I don't think it's have any role, because that's what, see, anti-VEGF we are adding for underlying occlusion or all those things different, but probably per se macroaneurysm, I don't think Avastin has a role, and definitely not injecting here is already, I think, is significant amount of hemorrhage. I do not know peripheral hemorrhages because heme is still there. I mean, that vitreous hemorrhage is there. Once you clear, we will know what it is, but it looks like having extensive hemorrhage as well. I'm not sure whether it's only posterior pole. If it is only posterior pole, I agree what Dr. Raja Narayan says. But if they're having entire subretinal space is full of him, probably I just clear vitreous hemorrhage and just because it's looking at already color has changed, alter heme around. So doing extensive retinotomy, clearing entire subretinal space, probably visual potential and is not that great, and also you are increasing the risk of PVR. That's what my assessment. But once you clear peripheral hemorrhage, we need to see how the peripheral retina is.
Can I make a point, Jay?
Yes,
Jay,
please,
can I
please.
make a point?
Please.
Yeah, I would have thought of giving pre-operative TPA and then do vitrectomy for this patient.
That can be another option, yes.
Yeah.
Another option.
Yeah, I mean, I usually like doing subretinal TPA like Aleksandra, but yeah, there are thoughts where people inject intravitreal TPA and then take them up. And yeah, I mean, there are, but I think that doing a once for all is the best thing, what Aleksandra did, right?
Aleksandra didn't tell us what she has done in this case.
Yeah,
I know, I'm keeping it a mystery. So it's very interesting because all the comments just point to how many approaches we have to these, right? And it also shows that there's no one great approach. So people have mentioned, the role of Avastin is very questionable in RAMs in general, both in hemorrhagic and exudative RAMs. And then, do you do TPA before? Do you put TPA and let it liquefy the clot and try to remove it? Do you do,
subretinal air?
Subretinal air. Yeah, and that's, it's interesting because the biggest issue also that comes up with RAMs is, for whatever reason, they're more likely to progress to macular holes as you put, anything under the retina compared to AMD patients. So a lot of Tamer Mahmood work with subretinal air combined with TPA and anti-VEGF is mostly in AMD. He actually excluded RAMs in a lot of his studies. So, and the other, I think, important point is you need to make sure that, usually in RAMs it's subretinal, but sometimes you can have in these subretinal hemorrhages from other etiologies, you can have sub-RPE component, and you want to inject subretinally and be careful. So this is what we did. So we're going to continue clearing, and it looked like there was some dehemoglobinized blood subretinally peripherally. And I'm not showing here, but we did a good depression. And here I'm using intraoperative OCT to find a good spot to go in, because I wanted to make sure I had space and that I was in subretinal location. And it's interesting, you'll see as we start injecting, for just teaching purposes, you can see, you think you're in, but you're just depressing and you're displacing the blood. So you need to make sure you actually in the subretinal space before you start injecting, because you can lose a lot of TPA. And just as we see with, there's a lot of subretinal injections now with gene therapies in clinical trials and not in clinical trials. But TPA tends to go peripherally because that's the path of least resistance. Because posteriorly we have a large clot, but peripherally it's just subretinal fluid and just maybe a little bit of the hemoglobinized heme. So we inject, and we think a little bit is going posteriorly, but not a lot. So we decided, we weren't sure what the visual prognosis was for this patient, and we decided not to work on removing the clot. The other interesting thing that comes up, a lot of patients with RAMs have sub-ILM heme, but I didn't have a very good view, I felt, to work on peeling ILM, and I wasn't sure what the component of sub-ILM heme was. So we talked to the patient. I told him that, the prognosis is not very good, but we tried our best. And this is him several months later. He actually did really well considering. And you can see that it was that RAM along the inferior arcade, the one that was closest to the optic nerve, that caused the whole problem. And all the subretinal blood has resolved. And on a good day, on pinhole, he gets to 2100, wow, which I think is a success for this patient. And to go back to the question, some of the questions were raised. Would you consider now doing laser to the other RAM? Would you treat him any differently or observe? And I would love to hear other people's opinions.
Duras, any thoughts?
A beautiful case, Aleksandra. I really enjoyed it. Do you have an angiography done after the surgery to look for further activity of the other lesions?
So we did repeat, and sorry I didn't put it, but it looked, the other lesion looked similar to previously. Yeah, I didn't see any activity.
Okay. So I think it was very managed, but we need to watch.
My thing was, we have treated the effect of RAM, but you see, the cause still remains. Anatomically, we have taken care of the hemorrhage, and patient has been lucky that gained good vision. But we still, I agree with Russ, do an ang and find out other, because the patient had multiple, areas, so that we could treat prophylactically. Or
I really just wanted to go back and think about it, because a couple of months ago, one of my fellow asked me a very interesting question, that when you see a RAM which is leaking on FA, like your case, and what do we do? So the fear is that if you do the laser, you actually might cause occlusion and other issues. If you don't do and it bleeds like this, then you are at risk. So how should we be approaching a case where you see an actively leaking RAM on FA, but there is no as such edema or bleeding or exudation? Should we be still going ahead and treating, or praying to God and just observing?
no, if there is no effect, I normally would not, but this patient has bled, so I would try to, do a post-operative.
No, in the beginning, I'm thinking about the baseline, at the baseline.
Masterly in action.
Yeah, that I don't think anybody will
I think there was something amiss about this particular case because the way it behaved with a central retinal vein occlusion like a picture initially, and then came out of the bleed. There must be something systemic going on in this patient which resulted in this particular massive bleed.
How is the
Yeah.
other eye doing, Alexandra? How is the other
He
eye?
has a vein occlusion in the other eye that I've been treating with anti-VEGF for now several years, and he's doing great. He's an elderly gentleman. He's, I think, 88, and he's actually a very funny elderly gentleman. He works still, and he wanted the best vision because he works at a gas station with his family, and he's very dedicated. It's interesting. I think to go back to Jay's point, it's very challenging in these cases when you see these RAMs because we're so used to give anti-VEGF for so many conditions, but the data for RAM and anti-VEGF is quite poor. And I think the other interesting thing was that we also taught that we want to go in very rapidly if somebody has submacular hemorrhage. And operate on them if it's a surgical candidate. This patient, we operated because he didn't come in. We operated 6 weeks after we saw him last. And for him, his vision decrease was almost immediate after the injection. So it was probably just the natural progression of his RAM. And I was surprised that even with delayed approach, he did relatively well.
Perfect. Excellent case. I think patient was lucky to come to the right person. Thank you so much, Aleksandra. I think
Better
we will
lucky
move
than
on.
good. Thank you.
Thank